Can you hear me if I don't have that thing there? Thank you so much. Thank you, Byron and Danny and the team for inviting me. It's a great privilege to be here. I also would like to acknowledge the traditional land on which we stand, the Eora Nation. As a midwife, I always think about how many babies were probably born not far away from where we stand today. Over 40,000 years that babies have been born on this continent. And I think that's a really important place to start. I'm unashamedly a midwife, and for those nursing students in the group, I'm going to try and recruit you very hard. And for those medical students in the room, I'm going to try and inspire you to do obstetrics and gynecology when you've finished your training. Because we need really good obstetricians and gynecologists to work alongside fantastic midwives. And we also need really good nurses to work with both those groups along the way. So while I am going to focus on midwifery, it's my field and the work I've been doing in recent years, the team is always big. The team always includes nurses, doctors, community health workers, physiotherapists, mental health specialists, a whole crowd of people. So that's the only way we will actually improve global maternal and child health, is that if everybody is involved. So this is a quote. Just before we start, can you put up your hand if you're a nursing student? Just kind of so I know where you are. Great. And a medical student? I think some of our midwifery students are here. Yes, hiding. Great, welcome. Thank you, everybody. So this is a quote that I really like from Aung San Suu Kyi about weaving hopeful dreams about the future. And I think regardless of what country you live in, regardless of the level of wealth in your country, having a baby is an incredibly special event. And every mother who's pregnant and gives birth wants the best for her baby. And every partner who stands alongside that woman having a baby wants the very best for babies. In my 20 years of being a midwife, both here and overseas, I've never met a family who didn't care what was going to happen. It's incredibly rare, and it usually means there's a whole lot of other stuff going on. Most of the time, families really want the best for their family and for their children. And so it is a shame, an international disgrace that actually giving birth in many, many countries mean you run the risk of dying, which is kind of what I'm going to talk about this evening. I want to challenge you about not very far away from our nice shores here in beautiful Darlinghurst, in nearby countries, women are dying giving birth, and that is an international disgrace that we need to do something about. So the global realities about giving birth, this is a photo taken of a woman in the Dominican Republic. At least she has her baby with her, that's a good thing. She has a bed to lie on, that's also a good thing. She doesn't have a support person with her, she's alone. There's another woman somewhere over there on the other side as well who doesn't seem to have a baby with her either. I do a lot of work in Papua New Guinea, and I walk into the Papua New Guinea labour ward where 15,000 babies are born every year. The biggest hospital in Sydney, there are 5,000 births a year. So 15,000 births a year is pretty crazy stuff. There are women on the floor lying who've had a baby overnight and who haven't got a bed on the postnatal ward and can't walk home yet. So they are lying on the floor as you walk into the labour ward, and you literally walk over them, which is why I think this woman having a bed is sort of a start. The other impressive thing about this woman is she has sheets on her bed. And in very, very many countries of the world, women do not have sheets. It sounds like a very simple thing, but it's about respect, it's about value, it's about making a mother feel special. In PNG at the moment, the beds have plastic on them, and often they don't even have plastic. So women are lying on plastic horrid sheets, or not even sheets. So around the world there are unacceptable rates of maternal morbidity, mortality, and the deaths of newborn babies. And even the women who survive, many of them have very long-term poor outcomes in terms of morbidity, and they have either physical or emotional or mental ramifications of giving birth. So you can imagine starting to be a new mother. You want women to be in the best of state, the healthiest they can be and the most nurturing and engaged they can be. And that is not the case in lots and lots of parts of the world. The other issue that is a huge problem at the moment is the global epidemic of disrespect and abuse of women. We're seeing it in Australia at the moment with the epidemic of women who have violence perpetrated against them, and the many women in this year at least who have died as a result of family domestic violence. So that's at one end of the extreme. And in the middle somewhere is this other end of extreme about health workers being disrespectful and abusive to women giving birth. And I must say, when I first started doing this kind of work, I was totally naive and just couldn't imagine that someone would be awful, a healthcare worker would be awful to someone giving birth. This is the most precious time. But it is the case that in many countries women are slapped and hit, they are treated poorly in labour, their babies are taken away from them. Sometimes their babies are taken away until they can pay their fees, and then they'll get their baby back or be allowed to leave, which just to me sounded completely bizarre, but it is the reality in lots of countries of the world. So if you're treated badly in a maternity unit or in a health centre or in an aid post, and for one of your babies, you're not going to go back for the second one. You're absolutely going to stay at home. So the reason lots of women don't choose to go to health facilities is because they were treated so poorly the last time. And that's not unexpected. So I'm going to show you some maps now which look a little bit weird compared to what you've seen global maps look like. These maps are from a website called World Mapper, which I love and I recommend you have a look at. World Mapper resizes the world according to where things are happening. So this is the number of births. This is what Global Mapper has done. So you can see annual number of births. Most babies are being born in India, quite a lot are still being born in China, and then a lot of babies born in Africa. We don't feature very highly here in Australia. We have a tiny number of births. We have just under 300,000 births a year. Countries in our region have a lot more births. So PNG looks little there, but it has a population of 7 million and a maternal fertility rate of about 7. So there's a lot more babies being born there. But in our region, there's quite a lot of births in Indonesia and less so in North America. So that's when the babies are being born. This is where money is spent on healthcare. Public health is spent quite a lot over here. This is Japan, this is Europe, this is North America. You can see how much money gets spent in Africa and how much money gets spent in the Indonesian archipelago and less so as well in South America. So I always think that's a good juxtaposition. Where are the babies being born and where is the healthcare being spent? It's not quite the same, is it? And then we look at where are the women dying in childbirth, and that's another quite shocking distribution. Most of the women who die in Africa or in India, and less so in our country. Although in Australia your chance of dying if you're an Aboriginal Torres Strait Islander is 3 times higher than if you're non-Aboriginal Torres Strait Islander. So we still have a lot to not to be proud of. But those maps, and there's lots of others on Global Mapper, I think are just interesting to kind of think about. So where's money being spent, where are babies being born, and where is maternal mortality? I'm interested that you've got David Cooper coming to speak with you soon. The map for HIV almost looks exactly the same as the map for maternal mortality. Africa's a bit more swollen, but essentially it's the same. So 800 women die every day due to complications in childbirth. So 800 women, that's about 2 jumbo jets, maybe 3 if you think about a smaller plane. Think about the controversy and hysteria there would be if every day there was 2 jumbo jets going down. We know your risk of dying in childbirth is highest in Africa, a 1 in 40 chance of dying. Your lifetime risk of dying is 1 in 40 in Africa. It's 1 in 3,300 in Europe. In Australia it's 1 in 9,000, quite a big difference in your risk of dying. Papua New Guinea is 1 in 120, although the Papua New Guinea data is pretty terrible, so it's probably much closer to 1 in 40. So that's about 300,000 women dying each year and about 3 million babies. So in the time that I'm going to talk to you this evening, about 30 women will have died in childbirth or complications related to childbirth, and about 340 babies, newborn babies, will have died. That doesn't count the stillbirths, so that's another 300 odd in the hour that I've been talking to you. This is a photo I took in Papua New Guinea in a very poor health centre. This woman, and and I go into a maternity unit in Australia and goo and gar over babies and twins. Isn't that wonderful? It's so exciting. You must be so pleased, blah, blah, blah. This woman, this was her 8th and 9th babies. And of course she was pleased and enthusiastic, and they were well and they were healthy, but I just couldn't help think, going home to 9 children now to look after and feed and clothe and send to school. That must be an enormous thing to take on as a family. So most deaths occur in what we used to call developing countries. These days we try and get rid of that language and we talk about income levels. So developing countries are mostly in the low to middle income threshold rather than developing. So what are these? What are these little pictures? Come on, we brave?
The Millennium Development.
Excellent. Well done. They're the Millennium Development Goals. We have about 100 days to go, about 120 days to go for the end of the Millennium Development Goals, which were put together in 2000, and they look at trying to improve things from 1990 to 2015. So by September, we've got to 2015. So I haven't given you them all here, but the ones that we're most interested in, or I'm most interested in, are these ones. So number 4 is child health, and the MDG was to reduce by 2/3 the infant mortality from 1990 to 2015. This one's maternal health. Essentially that's to reduce maternal death by 75% in that same time frame, and to increase access to skilled birth attendant. Skilled birth attendant is a midwife, a nurse, a doctor, a community health worker with some training, or any cadre who have training. So we don't class traditional birth attendants or village birth attendants or village health workers as skilled birth attendants. And that's a controversial area we can talk about later. This one is about HIV, malaria and TB, and essentially the goal 6 was to halt the progress of all those 3 conditions by 2015. So the reality is we won't meet the Millennium Development Goals. Some countries will. Some countries have done quite well on this one, but globally most countries, the majority of countries, won't meet all of them. The other one that's really important is Millennium Development Goal 3, which is about gender equity and about women's empowerment. And a lot of the things that will fix global health are about fixing primary school education for women. It's much more downstream. We're health workers, so we're going to start at the health end, but actually we should be putting much more energy and investment into the education side of things. The good thing about investing in education, in particularly young women, is that then you have a health workforce. They're the nurses, midwives, doctors, physiotherapists of the future, but they're not going to be any of those things if they haven't had any education. So teaching young girls at school and keeping them at school actually gives us a health workforce in the future. So globally, and this was done late last year, maternal mortality has fallen by 45%, so it's supposed to have fallen by 75% globally, so we're not going to be there yet. And only half of the women in the low to middle income regions get the health care that they need during pregnancy. And the health care that they need during pregnancy is pretty minimal. The basic standard is 4 antenatal visits, only 4. That's the standard. If you have a baby in Sydney, you're probably going to have 10 antenatal visits at a basic minimum. So, what we see globally as being minimum is pretty minimum. So these are the MDG scorecards for the regions. WHO, the World Health Organization, splits the world up into 6 regions. We live in this one, the Western Pacific one. This is, I don't expect you to look at the numbers, but obviously red means they're not going very well, orange is they're kind of getting there, and green is they'll make it in terms of meeting the MDGs by 2015. So Africa isn't doing very well. Africa's had a hard time, and HIV in the last couple of decades has not helped, obviously. Eastern Mediterranean is another region that's having a rough time. We look great. We look like we're doing really well, so we could all just shut up shop and not worry about our region. But you can imagine in the Western Pacific region, lots of the rich countries fit in. So this is Japan and Australia and New Zealand and lots of very wealthy countries. I'm going to show you in a minute now 3 of our near neighbours, so same data now broken down by countries. So Fiji is big, couple of islands, has a population of 800,000. They've done quite well on a number of things, including skilled birth attendants. They have a fabulous network of nurses and midwives out there in communities. They've got good transport systems. Lots of people can get to a health centre or a hospital. So they've done very well. They also have very low HIV prevalence and a low TB rate. Papua New Guinea is another story. Papua New Guinea has a population of just over 7 million. 85% of people in PNG live in rural areas, most of whom have no access to road transport, no access to driving anywhere. Has anyone been to Papua New Guinea to be in Port Moresby? Port Moresby is an interesting place because you can't actually drive anywhere else. You go to Port Moresby and you can drive 100 kilometres out of the city and that's it, because that's where the escarpment begins. And so you have to fly everywhere. And obviously, for most people in a poor country, you can't fly everywhere, so people don't go anywhere. You have to walk for 2 or 3 days, usually, to immunise your children, to get health care. So PNG is really struggling and won't make any of the goals. Solomon Islands is a smaller country with many, many more islands. They have something like 800 islands that they have to service, that people live on in the archipelago, and so that you've got to think about, do you have a health centre in each one of those islands? Do you put a midwife in each one? Do you put a nurse? Do you train a village health worker? Do you just get more canoes to move everyone to the bigger island? Where are your islands going to be? Like, it's a really complicated problem in the Pacific with these tiny big archipelagos of lots of tiny islands. What on earth do you do in terms of giving health care? So Solomons are doing better than some, but certainly skilled birth attendant, they've improved and their maternal mortality is better. The Papua New Guinea number here of 230, so maternal mortality is worked out, it's a number by 100,000 live births. So every country gets a rate, or a ratio, a maternal mortality ratio. In Australia, our ratio is about 10 at the moment. So PNG, and this data from WHO has a rate of 230. The country did their own analysis a couple of years ago and got 730, and a more recent analysis is probably 1,000. So their 230 is kind of hopeful, certainly isn't accurate. Solomon's is 93, is probably a bit more accurate because they've got a higher skilled birth attendant rate. So this number here means the numbers of women who have somebody with them who has some skills. So only 40% of people women in Papua New Guinea have somebody with them with some skills. So that's a nurse, a midwife, a community health worker or a doctor, which is incredibly low and one of the lowest in our region. So what do women die of? Essentially they die mostly of bleeding. 27% after the baby's born, so postpartum hemorrhage, either at any stage during pregnancy, but after the baby's come out, or other conditions like diabetes, malaria, HIV and obesity. Clearly in many low and middle income countries, obesity is less of a problem, although across the Pacific, obesity is a really big problem. And trying to address obesity is becoming quite a challenge because it leads to, there's a causation around, association with diabetes, obviously. So this is, a lot of women die from this, but mostly this is HIV. High blood pressure creates problems. Women are more likely to have a stroke or have a bleed. Having infections is a big problem. Obstructed labour, if you're in labour for hours and hours and hours and hours, days and days and days and days, the complications, obviously death, but also fistula, obstetric fistula, which causes very long-term problems for women. Abortion complications, I recognise I'm in a tricky building having this conversation about access to abortion and family planning, but we cannot put our heads in the sand, and I'm going to talk about it because there isn't any choice really. So access to safe abortion or non-access to safe abortion kills women around the world, there is no doubt about it. And blood clots are much less in a low-income country much actually higher in a higher income country. So why do women die? If there's what's going on, they're the conditions, but what's going on in the systems? Very many times, even when healthcare is available, it's pretty hopeless, I'd have to say, in some places, only because there's no drugs, there's no equipment, there might not be anyone who's had education for some years, and so the quality of care is pretty poor. In PNG, about 40% of health centres have no running water at all. And the vast majority of health workers in Papua New Guinea have had no continuing professional development. So they had their training as nurses or midwives or community health workers way back when, and many of them have had no further education. So we bounce in and talk about evidence-based practice and the things that you should do, and they're just surviving, really. So it's very easy to be judgmental, but the reality is it's pretty tough. The health system in many countries is not functional. The money does not go from A to B. The health department does not work. I've talked about disrespect and abuse of women. In many countries still, women pay for care, and this is from the obstetric ward fees, with an interesting obstetric spelling. I don't know if you can see that. This is in the Model-on Hospital, which is in Madang. Madang's a gorgeous town on the northern side of Papua New Guinea. And this is on the maternity unit. So admission fee was 20 kina, so just to be admitted to have a baby was 20 kina. 20 kina is 10 Australian dollars, and that's probably a week's salary for a subsistence farmer who's working in a market. If you had your baby before you turned up, you still got charged 10 kina. If you needed a caesarean operation, you got charged 40 kina. And I love the exempted patients, 60 years or over, cancer, asthmatic or children. So I'm not sure how many of them were obstetric patients, but it's good that they did think about exempting some. It's a shame that pregnant women weren't on the exempted list. There is a really big global movement around universal health coverage, that every single person gets access to health care, and they do not have signs like this. In PNG there's been an edict from the minister saying these sorts of fees should not be there anymore, but I trail around with my camera finding evidence that they still exist. Transport is an issue, as I mentioned before. Lots of places, you know, there isn't an ambulance. I've been in Timor Timor-Leste, they've built really on the sides of motorbikes, they've built these really groovy little stretchers so that if there's a motorbike in the community, you can attach a stretcher which looks like a sort of an old-fashioned motorbike with the carry thing the side. You put the stretcher and off you can get to the health centre that way. So that's, you know, being innovative, using a piece of equipment that's there anyway rather than is not needed. Nazrin, there's a seat there. Lack of knowledge, lack of literacy. If you don't know about going to receive care antenatally, if you don't know that that's what you should do, you don't go and do it. And if no one else in your village or your community's ever gone to care, why should you go? Not understanding what's needed. And the cultural factors, the gender issues for women are just incredible around the world. And we've done some research in the highlands of Papua New Guinea where we asked women why they didn't go to hospital. You know, they were quite a long way away, so it was almost obvious why they didn't go to hospital, but we asked them and they said that there was no petrol in the car and their husband wouldn't pay to put petrol in the car to drive to get them to hospital, and that they were frightened of walking in labour at night on the roads in case they got attacked. So, you know, what we think about the precious caring for a woman who's pregnant and looking after her and putting her in cotton wool and making sure she feels treasured and nurtured, that's not how the world is, sadly. I did ask the manager of the surgical ward in Goroka Hospital, which is near where that hospital is, and near where those women are, what was her most common reason for admission to a surgical hospital, a surgical ward. So think about the places you go for placement. What would be the most common reason? Maybe some elective surgery, maybe other things. The most common reason at Goroka was spear wounds from spear fights. It's like, whoa, I never thought about spear fights, but anyway, that's good. So you have to kind of be ready for all sorts of things. This is just another, I put this up mostly to promote what is a fantastic organisation called Women Deliver, and you can't really see it at the bottom. Women Deliver are a global organisation looking at the health and education of women and girls. The patron of Women Deliver is our Princess Mary, and the next Women Deliver conference is in Copenhagen next year in May. And if any of you want to go to beautiful Copenhagen and be absolutely inspired about global health, this is the conference to go to. I went to the last one in Malaysia, it was quite phenomenal. So Women Deliver are a huge advocacy organisation trying to, these are the data you've seen before. These are the delays. Women are delayed getting to help because they don't know they should. They don't have the education to think that they need to go. They get delayed in reaching a facility. They don't have transport. They don't have a way of getting there. And once they get there, they don't get very good care, either because there's no care to have and there's no carers who can provide it, or because there's not much equipment. These are the things that will make a difference. Access to family planning, access to modern contraceptives will stop women dying in childbirth. You cannot die of a childbirth-related condition if you are not pregnant. It's just not possible. So if you can reduce the number of women who are not pregnant because they choose not to be pregnant, we will reduce maternal mortality in the order of 40 to 60% around the world. We need good quality care, and so we need nurses, midwives, doctors, community health workers who can provide women and babies with good care. And we do need access to safe abortion services. It is the reality. It is happening out there. We need to make sure that if it is happening, it happens in a safe and appropriate way. If you're a baby and your mother dies, you're 10 times more likely to die before you're 2. And this is no disrespect to the very good men who are in the room, but the reality is that women without their mothers are likely to die because they can't get fed and they can't get appropriately looked after. So, investing in women makes a big difference, and I'm going to come back to that in a minute. So these things I've kind of talked about a little bit: quality care, drugs, access to drugs, really basic drugs is absolutely imperative. Access to contraception and safe abortion, and access to blood. Most places do not have what we see as a blood bank. When I worked in Africa, on a number of occasions I would leave the theatre to go and give blood and bring the blood back and run it through, because I was known to not to have HIV, so I was kind of a safe bet. But as a healthcare worker, you can only do that a few times. You can't do that every day. We tested, when I was working there, we tested whole family members often to give blood, and that's the double whammy when you have to say we can't use your blood because you've got HIV in this really crisis moment, having to have that conversation and then trying to have another conversation about your family member who's very, very sick and may not live. This one here is really important about counting deaths. It seems obvious, but unless we count every death and we know what every person dies from, we will never really know the magnitude of the problem or then how to fix the problem. So in lots of countries, in the Pacific at least, children's births are recorded when they go to school at 5. Which is great, because then you know how many children need to be at school. But you've missed all the children who've died before 5. And it's kind of getting a bit late for planning if you only know at 5 how many schools you need to build. So birth registration is really a very important thing to fight for in countries, and death registration. So a lot of what I've talked about so far has been about mothers, but clearly newborns are part of the package and you can't separate them out. We know that if a newborn lives and a newborn is well, again, that reduces the mother's chance of dying of maternal death. Because if her baby's alive and she breastfeeds for however long she can, it's likely she won't be pregnant again in a hurry. So she might not be pregnant for another 1 or 2 years. If her baby dies, she'll be wanting to get pregnant straight away, because she'll want to, it's a normal, natural thing, women will want to replace that baby. So her chance of dying from a maternal condition related to pregnancy goes up because she's pregnant again. So if we can protect the babies and make the babies survive, we actually ultimately stop the mothers dying. So just briefly, this is a graphic from USAID. USAID is the United States aid organisation. They put an enormous amount of money into aid. They've got this really nice graphic I'm going to show you about why invest in women. Why should we care about investing in women, particularly? And so gender equity, women's empowerment, really, really important. We know most deaths occur in developing countries, and having a skilled birth attendant, a midwife, a nurse, a doctor, a community health worker who's had training makes a difference. So 1 in 5 girls in developing countries who enrol in primary school never finish. 20%. That is an enormous number. And the data shows that when 10% more girls go to school, a country's gross domestic product increases by 3%. So 10% go to school, your GDP goes up by 3. So think, 26. It makes a difference. The more girls you've got at school, the richer your country's going to be. We do know, though, 1 in 7 girls will marry before they're 15 in low to middle income countries. 15 is too young to get married, because getting married means they're going to have a baby probably by the time they're 15 and 9 months. Girls who stay in school for 7 or more years marry 4 years later and have 2 fewer children overall. So if you start your childbearing very early, you're going to have a lot more children just because of your age, and you're also not going to be educated. So both those things make a difference. Sadly, more women in the world have HIV than men, and most women in the world have developed HIV from sexual transmission, and the rate of mother-to-child transmission is also very high. But we know, and I'm sure that David Cooper will talk about this, if you give women drugs in pregnancy and labour, you will almost remove their transmission of their infection to their baby. So you will make it, probably the transmission rate's about 2% if you've got drugs on board. If you don't have drugs on board, it's at least 20%. As soon as you add in breastfeeding, it goes up even higher. So in these countries, it's not an option not to breastfeed. In many places, it's more risky not to breastfeed. It's also a big sign on your head, I've got HIV in a poor community, when you're suddenly bottle feeding your baby and nobody else is. So HIV is a really important issue around maternal health. And this one's interesting. Women only make up 43% of the agriculture labour force. They are less likely to own land, and when they do own land, they own fewer amounts of land. But when women are given the same amount of land, there's a 10% increase in crop yields. So I don't know what the women are doing, but they're obviously very effective out there doing it. We need to give women more land. And this is one that we hear about in our country, and certainly across the Pacific, about women legislators. So this is women in Parliament. And our country has an equally big problem in this one as well. Countries where women's share of political bodies is greater than 30% are more inclusive, more egalitarian and more democratic. And that's only getting to 30%. That's not even getting to 50%. So investing in women makes sense and is a worthwhile thing to do. So what are we going to do about this problem? I'm a midwife, so I'm thinking we have to have more midwives, and hopefully some of you in the room will be midwives one day. But we were asked by The Lancet in 2011 to look at this issue, because we'd been banging on for years about what you need is more midwives in a country. Lots of countries don't have this thing called a midwife. They've got great nurses, they've got some other bits of training that somebody might have, they've got some community health workers over here, they've got some other kinds of village volunteers, all sorts of things. Lots of countries don't have a thing called a midwife. And by midwife I don't mean a direct entry midwife, I mean someone who's had midwifery training. So that might be that they were also a nurse and they did midwifery training, and so they can be classified in their country, regulated, registered as a midwife. So we did a big series published in the middle of last year looking at what does midwifery do and who can do it, and actually midwifery care can be done by a range of people. The most effective people are a midwife, because they can do about 80% of the things that women and babies need, but we also need doctors to work with us. We also need obstetricians and paediatricians. We also need people who do health promotion. They might be nurses who work in acute settings or other settings. So it has to be a whole package, as I said before. But it needs to be across the spectrum. So it needs to be pregnancy, labour and birth, and postnatal and family planning, all bundled up into people's training if they're doing midwifery training. And it's absolutely a core part of universal health coverage. So there are 4 papers in the series. There's another 2 to come, and they're accessible, publicly accessible from the Lancet website. What the 4 papers showed was that fragmented care, so having a little bit of care here and a little bit of care there and a little bit of care there, all from different people in different settings, in different contexts, should not be the norm anymore. And that in our country, as well as in low-income countries, women need a joined-up system. They do not need this fragmented system anymore. So the way that gets articulated in our country is that we're increasingly developing models of care where women and midwives work together through the whole of the pregnancy, labour and birth, postnatal period. The same group of midwives, the same group of women. In developing countries, poorer countries, that's much harder to do, but is still much more of a joined-up system that we need to do. And midwives are very important, but they have to be well-educated midwives. So they have to either have done nursing and then midwifery, or they need to have done a midwifery direct entry course that's the right length. And they need to be regulated. So they need to be part of a registration body. You're all currently registered with APRA as students, whether you're medical, nursing or midwifery students. When you finish, you'll be registered as practitioners. Lots of countries that is totally foreign and doesn't join up at all. So P&G forgot to register midwives for about 10 years. And we've only managed to help them do it in the last 3 years, and they've suddenly got 340 midwives because they've trained them and registered them. Lots and lots of countries, people are educated and then thrown out there, no regulation system, no quality control system. The other important thing about midwifery is that it optimises normality. So much of what we do in healthcare is about fixing problems, sometimes that we have created ourselves. So we induce women, we give them drugs, we make them lie on beds, we treat them really badly, and then we wonder why they get complications, rather than thinking about, well, what is the normal stuff going on here that we can support? When babies are born, we wrap up the babies and take them to an isolette somewhere and put them in a humidity crib that someone bought us. The best thing is to put the baby on the mother's chest, wrap the baby and the mother up together. Optimising normality. Don't do anything that doesn't keep mothers and babies as normal as you can. And also the other things around respect and communication and tailoring care to women's needs. So there's a real shift that we have to make from not doing it because that's what the institution wants to doing it because that's what that woman needs. And I think in all of your healthcare, even if it's not midwifery, we really need to think about shifting from what does the person need rather than what do we as an institution can provide and what's better for running of our wards, what's more functional. So the analysis we did in one of the papers showed if we had midwifery services, we could prevent about 80% of maternal and newborn deaths, including stillbirths, and that's a very big number. So lots of challenges. Like midwives are mostly women around the world, so they're disempowered, they're overlooked, they're invisible, they're not counted in regulation. People don't know what they do, so they don't worry about them. Standards in many countries are all over the place. Education or regulation standards are not consistent. And in lots of places, midwives are not allowed to do basic things. So they're not allowed to give the drugs that stop women who are bleeding from bleeding. And I look at that and think, well, that's no logic. We know that that's what's going to happen. Women are going to bleed. You need to be able to give the drugs. But their regulations say, oh no, that's complicated stuff, so we won't let the midwives do that. That's really crazy. Low status of women feeds into this, obviously. In lots of places, people are not paid properly or not paid for months. And there's this overriding thing around over-medicalisation that we fight against in Australia, but in some countries it's kind of happened and the horse has bolted, so to speak. So in countries like Brazil, the caesarean section rate is in the 80 to 90%. Parts of China, it's about 80%. And even in lower income countries, I was in Vietnam recently, and the caesarean section rate in the big hospital in Hanoi was about 70%. And I said, why? And they said, well, there's just too many babies being born. We can't run a labour ward. We actually don't have enough beds to run a labour ward. So the most efficient way is to move a whole lot of those women out and organise their surgery. Because actually A quick elective caesarean section probably takes an hour, but watching someone in labour and birth is 10 hours. So you can imagine why people do this. We'll just move everyone and do quick caesarean sections. We can get through a couple of hundred women in a day, whereas we could never do that in a labour ward. That's craziness, really craziness. Okay, so I'm going to keep moving. We've got a problem. We know that midwives are one solution. Midwives are not the only solution, but they're an important solution to start with. We also know that we can't put midwives or nurses or community health workers out there and not give them a joined up health system. So if they don't have access to drugs, if they don't have an ambulance and a transport system, if the phone doesn't work, they're not going to be able to do anything. So it's very important that whatever we think about a workforce, and I'm going to talk about midwives as the workforce, all the other bits are important. So I was part of the State of the World's Midwifery report last year. We surveyed 73 countries, the 73 poorest countries in the world, to look at what was going on with their midwifery workforce. And we included a broad spectrum of midwifery. We included nurses and doctors and community health workers in that definition of midwifery to try and work out because every country is a little bit different. 73 countries were those that account for almost all global maternal and newborn deaths, but only have less than half of the workforce that they need. So that's the first big discrepancy in the numbers. Only 5 of the countries have a midwifery workforce, and that's the broad definition of a midwifery workforce that can meet their needs. So Brazil, Peru, North Korea, although I worry about that one in terms of their numbers, and Azerbaijan and Tajikistan are the 5 countries. So really none close to us and none in Africa where the big problems are. Some of the numbers of the proportion of health workforce that these countries had, South Sudan had 6% of what they needed, 6%. Papua New Guinea had 49%. So these have a long way to go, these countries. We looked at what midwives can do. This is trying to have a global movement around supporting midwives in lots of countries, a vast majority of essential care when they're in a joined-up system, when they've got referral networks, when they've got drugs, when they've got access to complexity, when they've got all of those things. And they need to be in the facilities that organise all of those things. And the most important emergency issues are access to caesarean section, access to safe blood, and access to newborn resuscitation. And I spend a lot of time in PNG teaching newborn resuscitation. It seems like a really simple skill, and those of you who are in the room, if you ever can learn how to do really good neonatal resus and you want to go globally, that's the thing to learn. Because if you can resuscitate a baby very quickly with a small bag and mask, it's the simplest procedure you can do. You'll make an enormous difference to that baby's life, obviously, but you'll prevent that woman dying because she's not going to be pregnant again for the next few years. So neonatal resus is a really critical tool, and we can all do it. So this was the report. Again, it's available on the UNFPA website. We did it with the World Health Organization and the International Confederation of Midwives. The World Bank did an analysis in this report and showed that investing in midwifery education, this was done in Bangladesh, where the midwifery education was only 2 years, it was quite a short program, gave them a 16-fold return on investment and was thought to be one of the best buys in primary health care. It was up there with immunisation. So we know that immunisation is critical for primary health care. Having 2-year trained midwives was similarly critical. But it's a challenge to persuade the global community, and I still go to lots of countries where maternal and child health is way down on the list of things that are worried about. But I want to use a couple of good examples. And Afghanistan is a very good example of where change can happen. And we're very lucky to have in the room my colleague Sabra Tukhmani, who Sabra was the second president of the Afghan Midwives Association and is here with us in Australia doing a PhD and is a shining light of what Afghanistan has done in terms of leadership for women. So in 2002, the MMR, the maternal mortality rate, was about 1,600 in Afghanistan. There was hardly any midwives. given the size of Afghanistan. They have invested hugely in the last decade and continue to in education. 2-year program, 3-year programs for midwives, midwives in every community, regulatory systems being established, and very importantly, a strong Afghan Midwifery Association. The Afghan midwives are seen as the leaders in the region, and they're a ferocious mob together and have really made an enormous difference. 400 is still far too high. It needs to be much less than that, but to go from 1,600 to 400 in 1 decade in a country that has had such trouble is extraordinary. And so those women are really quite amazing. Ebola in West Africa has really challenged maternal and child health. We don't hear much about Ebola in pregnancy and childbirth, but Ebola makes being pregnant more dangerous. It makes giving birth more dangerous if you have Ebola. More importantly, Ebola has meant all the healthcare has been sucked out of the normal system and put into Ebola. So actually normal healthcare for people who don't have Ebola is almost non-existent. So Sierra Leone and Guinea and Liberia has just been announced as being Ebola-free, which is fantastic. But a big emphasis in educating midwives fast in those countries. A lot of money being put into educating midwives in 2-year programs or 3-year programs, and setting up midwife-led care models. So actually moving women out of anywhere where they might be exposed to Ebola in a health setting and setting up services. Ebola really exposed what happened in a fragile health system. So if you have a fragile health system that doesn't function particularly well and you add something like Ebola, terrible things happen. And so it's really been a very big lesson around building up the health system and the health workforce. So finally, I just want to talk about Papua New Guinea because this is where we spend most of our time, and my team at the WHO Collaborating Centre spend a lot of time doing this. We're funded by the Australian government. We've been in PNG in this project. This is our 4th year, and we put midwives from Australia and doctors, international doctors, into rural areas to try and build capacity. We're not a doing service, we're a capacity building working alongside service, but it's hugely resource intensive and hugely challenging. PNG is a wonderful place, but it's a very challenging place. It has 800 different languages, population of 7 million and 800 different languages. That's not just a different dialect, that's a completely different language because they're over the hill, and if you're over the hill you speak a different language to the people on this side of the hill, and you don't really like each other. That's the other interesting thing. So the tribal wars and things are quite phenomenal. We're working to, as I said, improve maternal and child health, giving people the kind of education that you've had around contemporary education, so doing group work, doing interactions, not being like I'm just here lecturing at you. We've been helping the midwifery educators think about new ways of training and making sure that the midwives, because the midwives when they finish in Papua New Guinea get sent to a rural area where they're it. There is no doctor. There might not be a doctor anywhere, on a phone perhaps, but maybe a helicopter, and no one's going to send a helicopter. So they have to do everything, things we don't do in Australia at all. So these are the midwives we work with, the course coordinators, and these are our team who, Australian, New Zealand and Malawian international midwives who are working in these 5 midwifery schools. PNG probably needs about 2,000 midwives. At the moment they have about 300, and they can educate about 120 a year. So they've got quite a long way to go, but they have to start somewhere. The 3 pillars of sorting out midwifery, and I think this is probably exactly the same for nursing and for medicine, is you have to have good education, you have to have good education standards and systems, you have to have regulation, you have to have people who once they're finished, they're regulated, that there's continuing professional development, that we sign a register, we're competent every year, that we do some continuing professional development education, and we have to have association. We have to be supported by nursing, midwifery and medical associations, that we need to be joined up with them. So they're the 3 pillars, and they're the sort of 3 things that we've been working on. And we hold 3 workshops a year where we bring everybody together. This was one in Port Moresby, and this is up in Madang. We bring everyone together and we talk about these issues together. And PNG's had, after essentially having no graduates for a decade, has this year up to now 320 graduates who are registered. It's quite a phenomenal thing to have them on a live register. And here they are teaching neonatal resus, which I think is a very important thing. These were taken last week at the International Day of the Midwife, and the society put these bundles together, and every woman who had a baby in Port Moresby General Hospital got a little bundle of some toiletries and some sanitary pads and a nappy for the baby and a sarong for them. Very simple things. And this is another midwifery student group up in Goroka. So, some messages for all of us. We need to be political about it, and the fact that Global Hands has even got an organisation and that you're here tonight and that you're thinking about it is hugely important and a very great first step. So we need to garner political will and energy. We need to talk about acceleration. So in lots of countries they've made a good start, but they need to now accelerate, and government and politics is going to help that buy-in. But equally mobilising. Around the world, women and communities are starting to say it's not good enough that women die. It's not good enough that we don't have access. In lots of places, people have jumped from a landline and they're on mobiles and they're on the internet and they're seeing what they should be getting and what they could have, and they're not liking it. So the mobilising is starting to happen in lots of places, and that's fantastic. Why do we care? Well, you care because you're part of a very good institution here at Notre Dame, where you're thinking about social justice and you're thinking about your world, your place in the world, and that's hugely admirable. We have a big social responsibility. We have to play our part. We do want to support Australian aid. When you watch tomorrow night's on the budget, look at what the GDP, the aid budget's gone down to. At the moment it's about 0.2 of our gross domestic product is spent on international aid. There was a thing on the news the other day where they went out and asked people in the malls about what they thought, how much money Australians spent on aid, and people were saying somewhere between 20 and 40% of our gross domestic product went on aid. So it's a lot smaller than that. Fortunately, Julie Bishop is very big on supporting women and children and gender equity, and we have to support her hugely around continuing to do that. But we will see less aid in the budget, we just will, and that's a problem, I think. We do need to support family planning. We do need to make sure that women have access to the right number of children for them. And importantly, don't export our own problems. So I get sent things like big boxes of textbooks, old textbooks to take to Papua New Guinea. I don't want to take an old textbook to Papua New Guinea. I want to take a new textbook to Papua New Guinea. Actually, I'd rather take an internet subscription to Papua New Guinea. The other thing I've seen in PNG is well-meaning organisations that send humidity cribs, and they go to rural towns that have no electricity, and they live in the corner of the nursery, generally not out of their plastic, and they put the pot plants on them or such things. In Timor-Leste, I've seen humidity cribs in the nursery that are open. They're just used as a crib. It's just a complete waste of time. If you're ever involved in a group that says we need to raise some money and send something, think about what you want to send. Send a scholarship to train a midwife, a doctor or a nurse. Send some subscription for someone to get internet time. Send things like that you know that you would want as an Australian healthcare provider. That's what they want too. We have our own challenges. We've got lots of medicalisation. Midwives and nurses particularly are not well recognised. We don't understand our roles. We need to do work here as well. So this is not just about everywhere else has the problem and we're pretty perfect. We're not at all. We need to look in our own backyard, particularly around Aboriginal and Torres Strait Islander health. There are big problems still to be solved for our Indigenous population. But we need to work together. No one group owns this space. We all need to work together. We all need to make sure that women and babies get a better deal. And as Ban Ki-moon says, bold steps to ensure that every woman and her newborn have access to quality midwifery services. I've just put this up here because I think it's this is a new thing that's been set up by the Swedish government after the Lancet series and State of the World Midwifery. It's a really great website. It's looking at midwives around the world and the sorts of work that midwives do, and you can see the range. It's not just poor countries, it's not just rich countries, it's everyone and everywhere in between. That's their website. So thank you very much.
I didn't come up before, but my name's Pete. I'm part of the Global Hands team. And so we're just going to have maybe 5 or 10 minutes of questions. So if anyone wants to get us started. Okay.
With the issue of contraception, how much do you think that relates to maybe like cultural or religious factors, or is it more a cost thing or a pharmaceutical company?
Look, I think mostly it's cultural and religious factors, although it's probably both. So in PNG, we've been having a very difficult time setting up one of the new midwifery schools because the local archbishop did not want contraception to be taught and refused to let the curriculum be taught as it was. He wanted contraception removed, and the nursing council rightly said, no, we cannot. Our women need access. We won't provide it in the Catholic hospital, and that's fine, but the students need to go somewhere else to get that training and to get that expertise. But that took 2 years of negotiation. So that's one example. But equally, there isn't enough of the drugs that women want. So they want the implants that last for 5 years, and actually getting enough implants into the country. So it's sort of both, but they overplay on each other.
Globally at the moment, what would you say the access to safe abortions is like, especially in the lower income countries?
I don't know the proportions, that's a very good question, but I reckon it's less than 50%. And if you think, many low-income countries, religion is an important part of their culture. I mean, high-income countries, of course, too, but sometimes in high-income countries we've got other things we get distracted on. And the culture there's less going on, I guess, in some, so people don't have televisions and other things to be distracted on. That's a simplistic answer, but I think probably less than half. And I think because it's so difficult, and whatever our personal beliefs are, and we all have a personal belief on this, if every woman had access to good contraception, they wouldn't be in that position. And if they get in that position, to be forced to have very unsafe care is terrible. And it's also the lack of understanding. One of our doctors in Papua New Guinea, who's a very good man, he's an obstetrician from another country who's working for us in PNG, he said to me the other day, oh no, this woman committed suicide because she was pregnant and didn't want to have her baby. And I said, she didn't commit suicide, she was trying to terminate her pregnancy, she wanted to live. She wasn't committing. I mean, he came from a country that didn't have an abortion. He couldn't understand that someone would do it. And that is challenging for all of us, I think. Trying to work that through is really hard.
How do you get around the legal aspects of it? Abortion is illegal in a lot of countries.
Yeah. So that's about advocating.
If an abortion and everything goes well, she can still be in prison.
Sure. So it's about, I guess, advocating on lots of levels, that it's about safety and it's about legalisation and it's about respect for women and
the government.
Yeah. And it's a very hard problem, obviously. I mean, it's hard in our country, it's hard in every country.
Thank you very much for your talk. I was just wondering, is the current midwifery course in PNG the same length as the course here? And is it also targeting current health professionals like nurses or nurses aides, or is it sort of new people?
Yeah, so the Global International Confederation of Midwives standards for becoming a midwife, there are 2 standards. One is a direct entry course should be a minimum of 3 years, and a course after being a nurse should be a minimum of 18 months. Interestingly, we don't have that second standard in Australia, so lots of courses are 12 months. In Papua New Guinea, it's 12 months at the moment. They've just gone through a big accreditation process, and as of next year, it'll be 18 months, because they recognise that what they need their midwives to do is so much more than what you can teach in 12 months. They've never taken non-nurses, interestingly. They've got the whole cadre of community health workers who've had 2 years of training and who are a terrific bunch of people, but they're trying to work out a way of them getting into nursing, doing an accelerated nursing course and then doing midwifery. But I think 18 months if you're a nurse is absolutely critical.
Professor Homer, thank you very much for your time and a great talk tonight. I was just wondering, you spoke about system level change, especially empowering and enabling midwives in these local sort of governments, in these local health systems. As future budding doctors, and nurses and midwives, some of whom in this room, what can we do as we make the transition from a student to a practitioner as individuals?
Very good question. So professional respect and working together and being collegial, and I guess understanding that whether you're a nurse, a midwife or a doctor, you bring different skills to the table, and we actually need all the skills. So no one discipline is better or more important or less important than the other. We need to work all together. So as new doctors, new nurses, new midwives out there, it's about coming together and working together. You kind of actually also need to like each other, I think, quite a lot as well. And I don't mean that in a romantic way, but, actually working together because we mutually admire one another's work, one another's skills, and we want to, be good together. So I spent a lot of my time, I was in Darwin this week, Darwin this week, talking about being nice to students. I had a room full of nurses and doctors and midwives, and we talked about being nice to students, because actually the students, so you'll stop being students soon, some of you sooner than later, so be really nice to students when you finish too, because they're the next generation coming along. But I think understanding one another and understanding the different frameworks that we come from and drawing on each other's strengths and spending less time saying what the other group can't do and more time thinking about what the other group can do and coming together. And kind of having fun together helps too.
I had a question about, so you mentioned before that some women weren't getting to hospital because their husbands didn't want to put petrol in the car to take them there. Is there anything that's been aimed at men to help them understand the importance of getting their wives to hospital?
Yeah, great question. So a lot of the work, particularly in PNG, is trying to do gender equity work, but working with men and women. Because if we just focus on women, and I've focused a lot on women tonight, I know, but there's equally important people focusing on men. So educating men, supporting men. One of the things that I think will shift is when we let men into labour in Papua New Guinea. Because in our country, that's when things started to shift in a way. Men saw what women went through in labour and childbirth and watched their babies be born, and I know there's a whole lot of controversy around that, but women get treated differently after that experience. At the moment, the men, it's women's business and men are absolutely banished, which I get in some levels about women's business, but I also think it's a missed opportunity. And so enabling men to be nurturing and caring is really, really important. So there is a lot of work being done around working out ways to certainly educate men, support men. There's been some big football players in places like Papua New Guinea talking about violence against women as being not all right. And the White Ribbon Alliance, obviously you'd know from Australia, but White Ribbon Alliance in globally is about maternal mortality, but in PNG we use it around both. We use it around violence against women, so working with men in positive ways, and then maternal mortality at the same time.
So to build on top of that, how do you go into like a country where cultural norms are not good for like the marrying children very young, and so very young maternal ages? How do you go in and implement change more than just advocating? Is there another way that you can actually create a positive change to practice in that whole culture? So I guess one of the things I'd say at the beginning is that we as people from somewhere else can't go in and do anything generally. So if any of you go and do global work, which I'm sure you will all, go in a walking alongside, because we can't make anything happen actually. So all the work I've ever done that's made a difference has been helping the people in the country, my counterparts, giving them information, giving them skills, giving them support, caring about them so that they can feel empowered to do the work. Essentially, we can't do anything. It's not our role and it's not our job.
And so we must be really careful when we go into countries not to do that. And that's not what you're suggesting at all. I think it's the working alongside, and actually supporting young women and young men to be educated, because once you get educated, the world kind of opens up and you can't think the same way as you thought before. And I think one other thing is, we've done some work in PNG, is giving particularly young women some leadership skills and some courage skills. So being courageous to go into a room of big men, and in PNG they're big men, both metaphorically and in reality. So as a young woman, it's terrifying to go into a room of big men and say what you think, because culturally you don't exist. So giving those midwives some skills, some courage skills, some leadership skills, some presentation skills. We do quite a lot of work around how to do negotiation in a meeting, in a group, which I can't do culturally because I don't come from the culture, but you can kind of give people some ideas.
What would you like to see in maternal and child health, the upcoming Sustainable Development Goals in the future of this space, and how we're going to monitor it and so forth?
Great question. There's been big advocacy over the last 2 or 3 years to have maternal and child health, or women and children, named in the Sustainable Development Goals, and that hasn't happened. Sadly, there are 17 goals that are going to be discussed in September in New York. There are 3 that look like we will fit in. One is about healthy for all. I've forgotten the actual names now. So it's about goal 3, which is about healthy for all. So I'm hoping underneath that there's something about maternal mortality, women and children. I think we have to keep measuring maternal mortality. I think we really need to measure maternal morbidity, because it's all very well living, but if you live with fistula, mental health condition, anemia, all sorts of other things, that's not very helpful. But we're not very good at measuring that, so that's a challenge. And there is a goal around gender equity, and I think women's education, girls' education will drop into there, because that's a really key. But I do think the skilled birth attendant, or I'd prefer it written as a midwife at every birth. That would be a much cleaner way to look at it, because skilled birth attendant gets very woolly. And counting deaths and making a difference to deaths would be the things.
Well, if you just want to join with me for another round of applause.
So on behalf of all this, I'd like to thank you for coming and giving us such an interesting and eye-opening talk in this very complex area of global health.
Thank you.
So we're very inspiring. So I'd like to present you this gift.
Thank you very much. Thank you. Of that talk a few times, and your questions were fantastic. So to all of you who asked a question, thank you very much. It's another thing about women being brave. Wherever you go, a little tip, be brave to ask a question. Even if it's in a room full of scary people, be brave to ask questions, because it's really great kind of skill to learn how to do. And then you get people like me having to think hard. So thank you.